Ciao mondo, hello world, hola mundo, hello mom, konnichiwa, ni hao, namaste. Again, we are in Rome at the Consensus Conference on Hemoabsorption Hemodialysis for chronic patients, and I'm here with Professor Cantaluppi, who is in charge of Group 1, dealing with
the indications for hemoabsorption hemodialysis, how to define and phenotype, identify patients who are indicated for this kind of treatment. So basically, we are trying to identify which factors may help the clinician to identify the patient in the whole population of chronic dialysis would have some possible improvement in the clinical aspects, in the clinical symptoms, uremia-related symptoms. So we identify the three main factors, such as the patient-referred symptoms, the objective signs by the clinicians, and also some biomarkers that can be different from biochemical solutes that we know to be involved in the pathophysiology of uremia-related alteration, to other performance tests that should be performed by clinicians to help to identify and to monitor the patients in terms of better removal of some substances that are involved in this.
So, to make people understanding, we are basically considering the fact that even the most advanced dialysis therapies today may not be sufficient in some patients to resolve specific symptoms, signs, or even retention of molecules. And therefore, hemoabsorption hemodialysis is a new technique that is supposed to overcome the limitation of previous dialysis treatments, right?
Yes, it's a sort of trying to fill the gap of diffusion and convection, in particular related to large molecular weight uremic toxins and protein-bound uremic toxins that are not really removed by the standard physics of dialysis or standard dialysis, such as diffusion and convection.
In your view, what percent of patients could be candidate for this type of therapy?
I think that this depends more by what we use to evaluate this kind of patients, because obviously we should have to increase the capability to look at some solutes that are not measured in the standard clinical practice, in particular what we were talking before, such as protein-bound uremic toxins, and also some performance tests. So we define the patients with, it's inflamed, but we have to quantify and measure what inflammation means, and so basically this percentage may increase if we use this kind of clinical and laboratory biomarkers.
So it's possible that to start with we can imagine 10% of the population, but maybe later on we can expand the indication to this probably to 20 or 30% of the population.
Yeah, probably also more if you consider that hemoabsorption, as we are discussing in these days, can be coupled with standard HD or HDF, maintaining the similar procedures and operational procedures that we perform in dialysis.
Okay, so your group will be certainly useful in the recommendation of which are the ideal candidates for this therapy, and possibly help people to make decision on whom to treat with this therapy.
Yes.
With this, thank you very much for joining today's Cappuccino. The conference is still ongoing, and we are likely to see the resolutions in the next day or so, and finally in the publication that will come out from the conference. Thanks for joining today. Excellent.